Good morning, good afternoon, good evening. My name is Ali Bazarbachi. I work at the American University of Beirut. And today I will be talking about the role of MRD in AML. So as you know, despite significant progress in AML therapy, many patients are still relapsing. And currently, the persistent presence of minimal residual disease following therapy is probably the strongest predictor of relapse in most cases of AML. So based on that finding, currently MRD monitoring should be considered as standard with at least a threshold for MRD negativity of less than 0.1%, which means 10⁻³ sensitivity of the MRD detection technique. So there are two ways principally to detect MRD by PCR for certain abnormalities, mostly nucleophosmin 1 mutations, as well as the fusion genes such as in core binding factor AML 821 and inversion 16. And in that case, the persistent presence by PCR of NPM1 mutation as well as the fusion gene is a very strong predictor of relapse. And in general, we do the monitoring after 1 or 2 cycles of chemotherapy, as well as after the end of induction, as well as after the end of therapy. Conversely, for patients who have AML but are not included in the molecularly affected subgroup that we just defined, then MRD monitoring should be performed by multiparametric flow cytometry. It's important to note that we should not be using mutations in FLT3, ITD, TKD, NRAS, KRAS, DNMT3, ASXL1, IDH as single MRD markers. These markers may be useful when used in combination with other MRD markers. And finally, there are abnormalities that we call the DTA genes, DNMT3A, TET2, and ASXL1. And for these, it's unknown whether they represent reliable MRD markers because they may indicate clonal hematopoiesis and persist even after complete remission in cured patients. Thank you.